Right, okay. So welcome everybody. Welcome to our second seminar looking at the development of complex interventions, particularly using co-design principles. And today we have Graham Smith and Rafaela Neighbour-Ganger from the Centre for Collaborative Innovation in Liverpool John Moores University. And in particular, they're going to tell us about the work of Living Labs. So just quick housekeeping. If you could mute yourself when you're not talking, that would be really helpful. Can you put your questions in the chat, and then we'll have the questions after the presentation, and then we're going to record this. So if anybody's not happy having their face recorded, then just turn off your camera. But hopefully everybody's happy with this session being recorded and then being made publicly available. Right, so I think Graham is going to talk first, so over to you, Graham.
Hi, good morning, everybody. So Rafaela is going to share a screen, and then I'm going to move the presentation on. So I think if Rafaela can share the screen. Yeah, looks like we're on. So what I'm going to do today is my part really is going to talk about the Living Lab and where it came from, and then Rafaela is going to talk about the evaluation side. And it's called Closing the Loop for a reason. It's about a methodological loop in some ways, which is that we'll be looking at innovations and a little bit about what do we mean by innovation, and thinking about them in the real world. So when we talk about research, we're kind of talking sometimes about, and I am generalizing, about things, interventions sometimes, or objects in a very controlled world. What we're interested in is the real world, and trying to focus on what the real world means and what that looks like. The challenge with that is that how do you evidence that real world, the innovation in a real world? How do we know that it works? How do we know, what does work look like? And there's some of the questions that started to be posed when we looked at the Living Lab approach. So next slide, Rafaela. So the Living Lab, or the Centre for Collaborative Innovation in Dementia, is located in Liverpool John Moores University, and it actually is a space, a physical space, and that was funded through European monies. The challenge with a physical space in terms of the pandemic is that everybody wants to be, for obvious reasons, virtual, and as we've turned to the new normal, then a lot of that has to be hybrid. So we also have to take on board that it's a hybrid working space, but we've been very lucky that we had the monies to fund a room and the technologies to be able to develop the centre. When we started in 2011, I had no idea what a Living Lab was, and certainly did not have all this staff that you see in a big long list of, and didn't really understand what a Living Lab meant and how it could position itself within Liverpool City region. And a lot of the development of a Living Lab approach came out of being engaged in a project called Innovate Dementia. So the Innovate Dementia project was about engaging with people living with dementia to develop innovations or solutions. That's how we saw it, solutions that could support them to live well and to meet the challenges of their everyday engagement with dementia. And that could also be individuals with dementia, but also their carers as well. Next slide, please. So in the project bid, it was actually written that we would have a Living Lab, and the project partners were from the Netherlands, Belgium, and Germany. Interestingly enough, the Netherlands and Belgium have been engaging with Living Labs for a number of years, and they had a sense of what a Living Lab would do and what it looked like. The concept of a living lab comes mainly from the Nordic region, though influenced from the 1980s in terms of MIT, which is that effectively when technologies and also interventions are developed, the issue is that people don't actually use those technologies and interventions. So, for example, if you think about your iPhone or your remote control, then do we really use it to its full capacity? Do we use all the bits, the gadgets, the apps, the software, the buttons, and how does it fit within our real world? So there was a lot of technology was being developed, but actually not being used to its full potential. So the Living Lab was really around having a pragmatic approach that effectively engaged with the user. And that was certainly within the technological space as such. It started to be situated in health through different people thinking about how can we ensure that some of the interventions that we develop actually fit the real world of the users. So that could be apps, that could be buildings, that could be services. But how does it make it different than co-production? And that was something that was a movement that and an approach that was working at the same time. So how does it look different from co-production? And I'll talk a little bit about that as I move forward. But the Living Lab in continental Europe is accredited. Living Labs are accredited through ENOL, the European Network of Living Labs. Now, not all Living Labs are accredited, and some areas would say that they are a Living Lab without actually having accreditation. Accreditation process is where you're actually evaluated. The interesting thing is of the 400 Living Labs, that there are not that many in the UK, and the ones that are not really health focused as such and not working within the health space. Some do little bits and pieces where they work in the health space, but on the whole, they're not very health focused as such. Most of them come from a technological, digital perspective, and quite a few come from a design perspective, including architecture as well. So we're one of 3 accredited health-focused living labs in the UK, and we're the only dementia one as well. That's something that, again, living labs across the world are starting to look in the dementia space, but we're very, very much proud of our roots coming from working with people living with dementia. Next slide, please, Raphael. So the Living Lab, what makes it different than co-production? And that was something we were challenged by, because I get to be known when I worked on the Innovate Dementia project as the dementia guy, but actually I'm the Living Lab guy. If you can work with people living with dementia, one of the most vulnerable groups in society, and this approach works, then you can work with any group of people and any condition. So what makes it different than co-production? The difference is that we are focusing on something called innovations, and innovations in the real world. So we're interested in being able to co-create innovations, which is something new or something that's being used within a new context. And we are very much focusing on how the user will work with that innovation. And one way of doing that is co-creating. So when we started to look at that, we thought about what research methodologies mainly used within the Living Lab space. And though it tends to be pragmatic, which is pragmatism is very much a philosophical movement, which came from the likes of John Dewey and William James. It's very much around how we use a research method for utility sake, not research for research sake. So one of the ways of thinking about a methodology that was suitable was participatory action research. Though there are other methodologies that can be used within the Living Lab space, but participatory action research is very much being user driven. Now, the Living Lab is also focusing on how something works in the real world. So the market in this case I noticed, I apologise, I think the slides are moving on quite quickly from that perspective. I think there must be in the background. So I'll go back to, if we go back, Raffaella, to the original slide. So pragmatic researchers are very much interested in techniques or methods that can assist them to address the challenge. So the first thing is to understand the challenge of living with a condition. In this sense, it's dementia, and then thinking about the appropriate method to assist the individual to develop a solution to their challenge as such. Next slide, please, Raffaella. So one of the things about living labs and participatory action research, and the difference, is that Living Lab has a principle around the marketization or commercialization of an approach. And we also are very interested in the partnership working side of things. And the reason I mention going out into a market in the real world is that we also have to engage not just the user, but also the commissioner. So we have to think about who's going to support the funding of that approach. And it may feel as if it feels a bit private sector, but actually if you look at the health service, then any intervention is commissioned, and you have to think about, you engage with those commissioners. And then you also have to think wider in terms of users. How do you engage with clinicians that are going to be using that approach as well? So even if somebody, for example, is living with dementia and they're using a reminiscence approach, then there'll be clinicians involved in that, and then there'll be carers as well. And then we need to think about how do we make sure it's robust? So from an academic perspective, we need to make sure that academics are involved in that process as well. Policy, government is also important in terms of how we influence the use of various interventions and solutions going forward. But we always are grounded by the needs of the user. We are always grounded by the needs of the user. And the reason we are grounded by the needs of the user is because when we talk about the real world, we're talking about the real world, which is a user's real world. And that's really important to understand what their real world is. Next slide, please, Raffaella. So we have what we call a quadruple helix. And as I've mentioned, government, society, business, academia involved, but in different groups. But we need to make sure that they're in the same room. Now, we don't mean a physical room, it's what's called a notional room. So if we are developing an innovation, we need to make sure that we get the right people in the room. However, it is always driven, when they're brought together, it is always driven by the user, the individual that's going to use the approach. And we follow what we call 4 phases. So if we look at innovations, they happen to be what we call in the different 4 phases. So people talk about co-creation and co-production are very similar. Co-production tends to be used quite a lot within the realm of developing services, but you can co-create services, and we have done that. So the first thing we think about is, where is the innovation? So open design is a blank sheet of paper. So we are sitting down with partners, the quadruple helix, and we are starting to think about what are the challenges, what would the solution look like? But the first of all, we need to understand the challenges. We also need to understand what's out there as well, because sometimes it may well be that people talk about using an approach, a solution, but actually it's already out there. And what we might do is co-customize it rather than create something from afresh. And it's very rare that there is something afresh that we have to, we develop on a blank piece of paper. So co-customization can also come in there. But if there is something that actually is a blank piece of paper, then we start to understand the challenges. We've scanned the market, we've scanned the landscape and understood what's actually out there. And then we're working with users to then start to understand what those solutions would look like. So for example, when we did some work looking at issues to do with using antibiotics, for example, and there were various approaches that were proposed, which the GPs could use machines that people would urine in and they would get their result and they wouldn't necessarily have to see the GP, etc., those kinds of things. Users talked about trust. I don't trust machines, I trust my GP, I want to see a clinician. Whereas a younger age group talked about happy to engage with machines and apps and so forth and so on. So each user, depending on what group they may be in, they may have different views. So we have to be able to capture all those views. And so that's open design. Co-design is where we're starting to, we already have a brief. So in other words, we might be asked to design something. So a prime example, a good example of that is that we were asked to look at the House of Memories app, which is a app that wasn't written at the time, but there was a House of Memories program, which was a reminiscence program working with people living with dementia. And the idea was, how can we use that approach within an app? So we then started to, so we had a brief, and then we started to work with people living with dementia in their early stages to start to think about what that app would look like, both in terms of hardware. So button pressing for the older adults was a key issue at that time, rather than swiping, though we do know people in the later stage of dementia are more comfortable with swiping than button pressing. So the first thing was to try and understand what was wanted and brief, and what actually was doable as in real world, and that changes the brief. So it's an interactive process between brief and what users would actually use within that real space. So what I may think may happen in the future, actually in the real world, the everyday here and now, it may be something different. And then co-development is when we've starting to we have a solution and we're starting to get into thinking about how that could be developed further or redesigned, and that starts to move into the co-customization space as well, which is that there already is an intervention that's being used, but how could it be used in a different context? For example, if we have a pathway for people living with depression, and we know we have a pathway, we try to understand how we could further develop that pathway in a way that takes on the needs of users. And we did some work around that. So for users, the pathway in depression was very much around a squiggly arrow rather than a straight arrow. And they had the opportunity to start to think about what a pathway within their real world would actually start to look like. So we worked with people living with depression and commissioners to start to co-develop, co-customize that approach. Next slide, please, Raffaella. So in relation to engagement, it's really important that we continue to engage at different levels. We were involved in other projects, or namely the Helium project, which was around thinking about the ecosystem as well. So innovations, interventions do not just happen within a vacuum. So the health and social care market is one of the, in the NHS, is one of the hardest to get into. So we need to think about what does the ecosystem look like and what does it need, and how can we influence policy so we have an uptake of innovations, interventions. So a prime example in the Nordic region, then when a intervention innovation is proposed, it goes through a living lab, and it might go through a randomized controlled trial, but it would need to do both. So it would need to be tested in both ways, and then there's an uptake. It's at the end of it, yes, it's effective, it does what it says on the tin, we'll start to use it, and then we'll start to monitor it as well. But slightly different in the UK, which is some people would ask, how do we get interventions, innovations into that space? And I attended a meeting last week, which was about mental health interventions, implementation, and there is a gap of 17 years from saying that an intervention has the evidence to say it works and then actually to be used in the real world. So if 17 years. Now, if we look at innovation cycles, they're far quicker in relation to technologies. So it's kind of taking that on board, but also understanding the landscape in the health service and how long it takes for interventions to be out into that real world. Next slide. So why co-create? And it's one of the things in relation to innovations interventions is that actually if you get users involved, and that's the same with co-production from the start, then you will reduce redesign. So you don't have to keep redesigning something, because you'll have taken all those views on board from the very, very start. So involvement of all participants is really important, but also its value as well. So when we work with people living with dementia, one of the things they talked about was not that there was a solution at the end of it, not that there was an app that's now being used nationally and internationally from the House of Memories, National Museum of Liverpool. It was about we were involved. We are valued, we have a voice. So co-creation, certainly participatory action research approaches, values the user, and they feel that value as well, and that's really important. So the process is important in that sense. And understanding knowledge sharing as well. So when we engage in research, we engage with participants, but do we engage with participants as true partners? Do they get something out of the end of that? Do they, why would they be involved? And sometimes research can be, in the future, it will be a good thing if you're involved, but the person doesn't see it at that moment in time. So we also need to think about working in a cooperative kind of approach where we value all, but sometimes we also think, what does the person get out of it? Do they get a free access to an app that can actually support and change their life? What's in it for them from that perspective? And that's really important. It's not always about monies and technology. It can be about feeling that they're changing something. And then it's about sustainability as well. So if you follow a robust process, then that intervention innovation will continue to be used. There's evidence for that, including its cost effectiveness. And Referral is going to talk a little bit about that in terms of closing the loop. We have a process that we can clearly say is supporting sustainability, but also scale up as well. So if we know it works within one area, we can start to then develop it for other areas and work in the same process, and the uptake is more guaranteed. And that's only guaranteed if we work in partnership. So it's not just about working in Liverpool City region, it's also about thinking about the North West Coast, nationally and internationally. So if we use an approach here, can it work in Denmark? Can it work in the Netherlands? Can it work in the UK? And vice versa. And that may seem a bit of a strange one, but I've been involved in conversations where an intervention has been used in Finland, for example, or Estonia. And when we've come to the UK, the question asked is, how do we know it works in the UK? As if the Finnish participants, the Finnish area is so much different than the UK. So there's always a need to say, well, we need to use an RCT within this area, as if somehow it's different as such. And there is an argument that it isn't different, it's just the way we actually commission and understand how we implement interventions internationally. And the other thing is that we need to think about its impact on the health and welfare system. So it's not just about getting an intervention out there, it's also thinking about health outcomes. So what's the impact on health outcomes? So an interesting thing when I think about living with dementia across the life course is that we very much focus on, when you work with people living with dementia, that we work with people living with dementia. We don't think about the prevention agenda as well. So if we develop an intervention that supports young people, and Raffaella will talk about this, then what is healthy for the heart is healthy for the brain. And what's a good start reduces mental health challenges, will also be potentially a modifying risk factor in dementia in later life as well. So a lot of the interventions and approaches we use within the early stages of life for an adulthood can also modify risk factors going forward. So it's understanding where the intervention fits within the lifespan, but also within the ecosystem. Next slide, please. So these are some of the projects that we've been involved in. Innovate Dementia really was around starting the process of using a living lab. The Health Innovation Exchange and Helium projects ran together. The Health Innovation Exchange project was very much about implementing this process across a wider health landscape and engaging with more conditions. Helium was very much about how we influence the health ecosystem landscape and influence policy going forward, and also understand innovation good practices. And health matters was very much around, and is very much around, closing the loop. So if we co-produce, if we co-create things in the real world, then how do we know, how do we evidence them? And Health Matters is given this opportunity methodologically to start to understand what that would look like. Next slide, please. So Innovate Dementia, as I've mentioned before, was a project engaged with people living with dementia to support them to develop solutions to their everyday challenges living with dementia. And it was very much focused across Northwest Europe, thinking about how we could improve the quality of life living with dementia, but involve people living with dementia in developing those solutions. And the Living Lab approach was an approach, as I've mentioned before, that's used across Europe. And then we started to use within the UK as well. And that was something that developed our starting place as such. And the Centre for Collaborative Innovation developed out of that approach, and that then was accredited as the Living Lab. Next slide, please. So a summary of a co-creation process within that. So we brought 14 innovations into the health and social care system. So if we're working on a memory enabling app, then we would understand what the challenges are living with dementia. We would then start to work with individuals to co-create that type of approach, and the solution could be a memory enabling app, for example, working with a company. Next slide, please. So the most important thing, I think, of all of this is understanding, is creating an environment where you listen, listen, and listen again. So once you know you've got the brief right, then you can then start to move on to develop the solution. But listening and understanding the real world, and then prioritizing the approach that will work at that moment in time, is really important. Next slide, please. So helium, and I always pull that not the gas, because everybody starts to think that it's something to do with helium gas and squeaky voices, but it's a very long title. But it was very much, again, a European funded project, which was looking at the health ecosystem and the approach of living labs and how they could work together. So if we look at Liverpool Health Partners, they talk about the Liverpool model, innovation model, and living labs is part of that, which is an open innovation co-creation type approach. And there are areas that are using that approach. For example, Old Hay used that approach within their innovation hub to co-create innovations for the patients, people, service users they work with. But how can they work together? So rather than actually having different areas that do different things, or doing the same thing, then how can we make sure we bring everything together in a way that works towards, I would say, the end point, which is improving the quality of life of people living within the Liverpool City region. So how do we do that? The first thing was to identify good practices, and the next thing was to influence policy makers in relation to thinking about the policies going forward that utilize all the assets appropriately in a way that is lean, but also uses those the right assets. Next slide, please. So the Health Innovation Exchange project, as I mentioned before, was very much around wider than dementia. So dementia was included, but it was engaging with small and medium enterprises to offer a living lab approach that would support them and people living with conditions to be able to start to develop sustainable solutions. That was a 3-year project, and out of that, some of the learnings, certainly for me and others as well. So the innovation agency, part of the NHS, was thinking about how do you, once you've got them out there, how do you measure them? How do you close the loop? Methodologically, we know the Living Lab looks like a participatory action research approach. We know what the partnership arrangements look like. We know how to, to follow a Living Lab type approach, how many workshops that would be, so forth. But how do we measure it in the real world? And that was some of the learning that came out of that. Next slide, please. So other things that we learned as well is commissioning elements are not sufficiently strong, and there's the links that are a challenge in relation to the health and other sectors. So how do we work across health and social care? Data was always going to be a challenge and still is a challenge, that data sharing. Certainly at that time when this was written in 2019, how do we share data in a way that we could model the world? And the pandemic in some ways has helped us think about that. Engaging effectively and robustly was something we need to think about. So again, a living lab type approach, an ecosystem that was influenced by that was important. And also thinking about how small and medium enterprises, the commercial sector, could fit in with the NHS and social care as well. A lot of these things are being addressed to the industrial strategy and also learnings from the pandemic, but there's certainly still work that needs to be ongoing. And part of data is also understanding that if you have an innovation in the real world, when you introduce the innovation, how do you know what the landscape looked like before? Can you measure the before, and can you measure the during and after? So how do you know, how can you compare? And sometimes that's a challenge because we don't have the data. Next slide, please. So these are some of the things that we did in terms of outcomes. So we worked with small and medium enterprises, but we also influenced the policy side, the ecosystem going forward as well. Next slide, please. So we then moved on to what's called the Liverpool Health Matters project, and this is the closing the loop bit. So methodologically, how do we measure things in the real world, and what does that look like? So I'm going to hand over to Raffaella. So next slide, Raffaella.
Hi everyone, good morning. My name is Raffaella Gang. I work with Graham Smith at the Liverpool John Moores University Living Lab, and what I'll bring to you today is the second half of our presentation that will focus on how we move from the methodology of a living lab, how we close the loop using real-world validation, and what it is a real-world validation. Obviously, you probably think we are making up concepts. We probably are, but they are not that random. So we did a methodological systematic review to try to understand how real-world data is being used to validate health innovations. We know through this process, for instance, the poster that you're seeing on your screen was produced in 2019, pre-pandemic, and at the time we identify close to 1,000 records that use some sort of definition of real world. This search was conducted pre-pandemic. Post-pandemic, that number exploded to over 4,000 records because the vaccines start to understand the need of also beyond testing in a randomized controlled trial, how does the vaccine works within the population in a real world setting. So we had to do our search again in trying to understand how all this process changed through the pandemic. So we did identify a significant amount of articles describing the importance, the benefits, but also the limitations of real-world evidence and decreased prevalence of use of real-world data. That is defined as an information that is gathered through observations of routine clinical practice from multiple sources that can be linked together to provide a meaningful understanding of patterns. So real-world evidence is the analysis of real-world data from a study design that have a high degree of pragmatism. So in the second iteration of our review, we included 33 studies to determine the nature of the real world and what are the elements used in each of the studies that they define themselves as using the real world. It was shown that while the authors use a wide variety of terms to describe their studies, they can be aggregated in three categories: the pragmatic study, the proof of concept, but also there was need for another definition that would take in consideration the evidence of the impact of the innovation in the population rather than the evaluation of the innovation itself. That's why we propose this new concept of real-world validation. That is a methodology that uses real-world data to determine in a non-controlled environment effectiveness and the outcomes to patients, staff, and the health economy of a health innovation. So real-world validation, it is different from randomized controlled trials. Obviously, we know that randomized controlled trials are still gold standard in terms of clinical guidelines. They are time and resource intensive. They lack generalization and are typically restricted to the evaluation of specific interventions one at a time. While real-world validation does not demonstrate efficiency because it does not collect data from a controlled environment where the causality is clearly established. However, it does has its benefits. For instance, one of the studies that I'll briefly share with you today is the validation of a falls prevention app in the northwest of the UK. So we know that falls account for considerable cost burden for the NHS. And we also know that multifactorial risk assessments and individualized intervention have the potential to reduce falls and injurious falls. So we wanted to assess if a multifactorial fall prevention digital application would lead to a reduction in falls, but also in injurious falls in care homes. So we use real-world data from 32 care homes in the Northwest in a retrospective multi-center case control study. And the intervention was a digital app that would, sorry, this was not supposed to move. Okay. As I was saying, the intervention was a digital multifactorial risk assessment app that would provide a tailored fall prevention plan that would link each risk factor with appropriate preventing interventions that would be tailored to each one of care home residents. And our main outcomes was the rates of patient falls per 1,000 occupied beds, and the rate for injurious falls per 1,000 occupied beds across 12 months. So we realized that there were 22.3 fewer falls in the intervention group, and there were also a 35% lower harm injurious falls in the intervention group. And there was also a difference between intervention and control in injurious falls, resulting in ambulance calls to the care home and patients arriving to A&E. So we conclude that in this real-world validation, that the implementation of multifactorial falls prevention digital app was associated with the significant reduction of falls and injurious falls. In this particular case, the data was acquired from the app itself, from how the app was being used across these care homes, but also data acquired through CCG and the borough city council from the 2 boroughs across the Northwest region. So data was harvested from patient records, digital apps, and other type of secondary data. So another project that we are using, not just Living Lab, but also real world validation. How did we bring these 2 elements together? Is a collaboration with Alderhay Children's Hospital on the validation of children and young people's mental health service single digital point of referral that is being called CIP has one. So what is the problem? So we know that children and young people's mental health services.
No, I'm watching a webinar.
Sorry, there was someone talking. We know that children and young people's mental health services in Liverpool and Sefton were paper-based, and paper-based referrals were inefficient. They would generate delays between appointments and obviously would eventually have a negative impact on children and young people's mental health outcomes. Nationally, we also know that over 300,000 children refer to CUM services. Only less than a third would receive treatment within a year, and another 37% would not be accepted into treatment or discharged after assessment. 32% was still on a waiting list at the end of the first year. So we do know that access to mental health services is still one of the major issues around children and young people's mental health. So Alderhay decided to tackle this issue by developing a pilot project with NHS England that was supported by NHSX and also their partner agencies to develop CIP as one, so children and young people as one, to improve digital access and obviously innovate how children and young people would have access to mental health support. They co-create this new platform, and we're gonna, in the next steps, we're gonna see how. Just to let you know that the CIPS1 is a web-based platform that produces a single data entry point for referrals and appointment booking, but also provide resources and help to children and young people while they waited for their appointment. It was co-created with children, young people, families, and healthcare professionals in order to obtain, obviously, as we mentioned previously, a better solution for the problem that we have already identified. So it was co-created using a user-centered research design methodology that will put children and young people in the center, but also their families, the professionals that would potentially use this innovation. 26 children, young people, 31 parents, and 32 health professionals were listened, and they formed an open innovation groups. Participants were recruited following a response to a call via social media and via invitations through their multiple events that were already on with their associate partners. And further on, there was established workshops and focus groups where they tried to contact even further participants. So the process was started in January 2020. We know that we'll have the pandemic in between, so a lot of this work was done online, and that was one of the limitations of the study, was the fact that it was limited in terms of the scope and the spread of their recruitment, and that's something we try to overcome on the iteration of the work we are doing now. So as I said, you started in January 2020 and the innovation was launched in May 2021. The innovation went through a series of 5 iterations, which you can see described in the slides on your screen. So the 6th iteration was the current, let's say, version of the website that was launched and is still and is being used as we speak. Originally, it was aimed to deliver wider than just a website. It was the idea to be a digital front door concept for comms and partners services to improve access to information and services, develop these single and connected platforms and digital engagement tools from pre-referral all the way to post-treatment, ensuring a cross-communication for the patient. It was supposed to be a prototype for digital referrals from partners and self-referrals. It would enable digital signposting and referrals to social prescribing, for instance, and other type of resources. So there are still elements that are still under development. As such, when we start working with Alehay in last September, idea was to look back into the platform and trying to understand what were the points that could be improved. And we applied for further National Institute of Health Research funding to allow us to go back to the platform and question how the platform is working and how can the platform can be improved, particularly be more inclusive to a more diverse audience across Liverpool and Sefton. So we do have planned 3 events for co-customization. So we're going back to the methodology of Living Lab to co-create a new iteration of CIPS1 through these 3 Living Lab events. At the same time, we also want to understand how the platform is being used. It was anticipated that the platform will improve experience, would improve communication and access to information from young people, for their families, but also for wider stakeholders. So we are harvesting data from the website using a real-world validation methodology and trying to evidence if the platform it is effective in terms of reducing waiting time for the first appointment, reducing waiting time for a letter of admission, decreasing admin time, decreasing clinical staff time, reducing errors in transcription or referrals, improving referral experience by children and young people and their families, and improving access to mental health servicing and support. So we are trying on this particular research project to bring these 2 methodologies together in terms of co-designing, co-creating, co-customization and innovation. And after that innovation has been launched and is being used for 12 months, harvesting real-world data to validate the effectiveness and the health outcomes for children and young people, for their families, but also for the services and commissioners of this particular innovation. So we are looking into the ecosystem of this innovation, and that's why we thought that would be a very interesting example to bring you today in terms of how we close the loop of these innovative methodologies. Well, thank you very much for listening to us this morning. You probably do have some questions for me and Graham, and I'll also leave you here our contacts and our Twitter handles if you want to be in touch. Please do.
Thanks very much, Rafaela. So we've got a couple of questions, and we've also got some comments. So Milan, Josh, you've got a question about does co-creation involve carers and how to involve people. Would you like to voice your question yourself so that you can say it better than me?
Certainly. I was thinking of the context of dementia, where people might often lose the ability to speak. In the early stages, it might not be so obvious. It might simply be forgetfulness, for example. But if you're developing interventions that might help such people, sorry, can you hear my voice?
Yeah.
Okay. So in the earlier stages, particularly, I wondered how you involve the patients as well as the carers in designing your intervention. I imagine the carers have to play a large role if, for example, the patients become inarticulate at some point. So are your interventions intended for people at all stages of the illness, or more the earlier stages where they can still respond to instructions and so on?
Yeah, I'll address that question. It's a really interesting question, and one that's quite challenging. It tends to be working with people in their early stages, certainly around the work that we did on Innovate Dementia. And one of the things that we had to be very careful about was that it is important to involve carers, but sometimes people with dementia don't speak when carers are in the room, and vice versa. So sometimes we have to work together with carers and people with dementia, and also split the groups as well, so we get the voice from both groups. In terms of the later stages of dementia, then we are involved in a project. We've got a PhD student at the moment, and we're thinking about when innovations are targeted for people in later stages. So, for example, we're looking at immersive technologies, and they're being used in care homes at the moment. How do we capture the voice of people in the later stages? And lots of research really focuses on capturing the voice of the carer on behalf of. But there are observational methods we're starting to develop. People might say as a carer, informal, formal, the individual engages more in terms of speaking, so forth and so on, and that can be measured through those observational methods. So we're starting to look at how we can co-create a observational method that can be used in most care contexts, and also is very user friendly to make sure that we do capture that voice, whether that voice be through the way a person interacts, their non-verbals, so forth and so on.
That sounds like a very difficult challenge, because people go into care homes when they're in the latter stages, and so it'd be that much more difficult to get something that works. So good luck with that. Thanks so much.
Thank you.
Thanks very much. Peter Lloyd, you've put a comment in here about disinventing, you've called it. Would you like to elaborate more on that?
I can unclick my face, should appear somewhere, I suppose, because I've opened up the video.
Yeah, I can see you.
You can see me, I can't see me, but that's no problem to me. Okay, let's set some context for me first. My wife's had dementia for 12 years. She's in a care home. She has what they think are called seizures, but I'm not sure they are. She spends half a day in bed and half a day in a wheelchair, being hoisted from one to the other in a lift. All that sounds fine, and it works. So that's where I'm coming from on this. I see the real world, and this is where I make my entry point, in very, very real terms, with one I love, who is subject to this in late dementia. But I'm an academic, so the comments I put in the chat are about the fact that a lot of the research that I see, and I see a lot of it because I audit it, kind of abstracts from the context in which dementia in this country is actually regarded. It is regarded, as you know, has been since 1948, as not a primary health condition, not an NHS matter. It's an adult social care matter. It's delivered by private companies, many of them now offshore in the care home business, and by small, struggling private providers who. So context in this sense is that the biggest thing one has to disinvent to be able to get as creative, and I've seen it in Holland and Belgium as they are, is to disinvent this mindset. And we don't, because it's a big job. I'm not saying, you know, we get out with banners, but it seems to me that we have to acknowledge in our research that this is the context in which we operate. It's almost a kind of health warning to say that in the UK, what we can do in terms of innovation is limited by the context in which we are to operate. And what that means is that in the end, the innovation is not an NHS matter, not in this particular case. It will be a private sector business, small, large, whatever. It will be the local authority contracting process. We've got a project running on how assessment is done. And I just wish that I love what you're doing. This is not a critique. It's just that I say this everywhere I go when I hit the dementia story. People in the research business, like the people in Alzheimer's UK, have got to stand up and say, we operate here within a very specific context. Within that context, we can do these things. That's the real world. So when we use the frame real world, I think if you were a critical realist theorist, which I once was, you'd say, well, hang on, this is the observable world. It isn't the real world. The real world is run on different parameters. Sorry if that's a long speech, but let me just sum it by saying, I love what you're doing. I think it's very good, very interesting, very tricky. And so my two comments, the EU one is particular. I've worked with people. I have a cousin in Belgium in a care home, and I worked with the Dutch on living labs for architectural design and for urban design. It's a different world. The real there is not the real here. Sorry if I've taken your time.
That's a really good observation, and actually you contextualize the challenges that we've had for the last 10 years. And certainly in relation to innovation within health and social care is a real challenge. It's only over the last few years have you started to see journals thinking about how do we publish work around innovation. It's very much focused on the controlled type trial, which may or may not, and usually may not, get into the real world as such. And disinventing is an interesting one, because we think about in innovation around disrupting, and you'll have probably heard that term. Disinventing is really important because there are a lot of approaches that are used within health and social care, which you could argue, why are you using it? And what's your evidence for using it? And yet, if you want to get something new into the health and social care market, they ask for evidence, but they don't ask for evidence of the approach they're already using as such. So, yeah, it is a challenge, and the Netherlands and Belgium are completely different in the way that they commission and think about the use of innovation and how that is driven as well. So the Helium project was very much about chipping away at that and trying to get people to think differently. It's still a challenge, and certainly within universities, it's a challenge as well. We have what we call the knowledge exchange framework now, and we're starting to focus about knowledge exchange and its relationship to innovation. But yeah, I feel it's early days. I mean, I've kind of been in this space for over 10 plus years and doing this work for that period of time. And slowly, I think we've gained credibility through actually, in some ways, starting to move in the research world. So we talk about research to innovation, innovation to research, which is a shame in some ways, because I do worry about whether we dilute our approach. And also Brexit has had its impact as well, because of course there's the challenge of working internationally, which we seem to be well known internationally rather than necessarily nationally. So living labs in this country is an unknown space, whereas it's well known across continental Europe and across Australia, America, China, you name it. It's not something when I go to do presentations internationally, people are not really kind of thinking, well, what do you mean by living lab? It's an accepted norm in that sense, certainly within the commissioning space. I would like to see in this country, taking on board what you've said, commissioning that is underpinned by living lab approaches, and it's not just focused on RCTs. I'm not saying that we get rid of RCTs, I'm saying that it's complementary and that we work in a way that you have living labs and you also have those empiric methods as well. But no, I absolutely agree with your comment, and thank you for that.
Great, thanks very much. Just scanning through the questions here. Milan, you've got another one about falls in particular. Do you want to voice that?
I can take that one. What's the question specific on the falls? And any methods used particularly often falls?
Yes.
So,
Milan, do you want to voice that question?
Sure. I was only thinking of the very practical issue that old people often fall, and I'm just thinking that you've observed all these methods being used in different places. Is there any particular method that you use particularly often, find particularly useful? I mean, I just wrote down one which I could think of, but that's very much a layman's perspective. Have people who worked on this problem noticed that anything's particularly useful?
so our work focus on the validation of an app that's called Safe Steps. So Safe Steps was co-designed with care home staff, commissioners, but it was built from the recommendations from the NICE guidelines, focus on multifactorial falls prevention, but also on the recommendations of what, for instance, can be developed in terms of an individualized and a personalized fall prevention plan that would match, for instance, those particular risk factors. For instance, is there a hazard in a particular care home that most of the residents tends to fall around? Is there an issue around medication needs to be adjusted? Is there an issue on eyesight? And so on and so forth. So it's about more of a multifactorial intervention than individual types of particular interventions. The literature also show that the weak evidence there is focused on the multifactorial risk prevention and multifactorial interventions around those same risks.
Sure, I'm sure that's the right approach. I just wonder whether anything had stood out as being particular. I mean, you mentioned, for example, looking for hazards. That's one example, you know.
I don't have particularly here, but we can share, because we did an analysis of the different risk factors. I don't know it by heart which the ones that were statistical significant, but we can share that study. So the paper is being reviewed at the moment for publication, but we're more than happy to share those findings.
That's fine. I wasn't looking for statistical evidence. I was really referring to an impression that you may have noticed that certain things are more useful than others, but thanks anyway.
Thanks very much. I'm just scanning for other questions. Adrienne, you've put in the question. You are asking a particular question about the Falls app. Would you like to ask your question?
Hello. Hi. I was just actually wondering, the app, the multifactorial app that was mentioned, Refalls, is that actually available for people in care homes to download and use? Falling is a real issue and concern for us in the services that I support, and anything. We've looked at a number of documents and advice and things, and we're just open to any guidance at all that can help us keep people on their feet, really.
We know the app's been commissioned by the Referral Borough Council, by Graham, help me. Do you remember the boroughs?
Yeah, so it's not available for individuals to use it, but it is being commissioned by councils and care homes. So an organisation could commission it, and the company is actually called Safe Steps. So you could have that conversation with the company. Obviously, the Safe Steps app is, though it's a general offer, it's also it's implemented on the basis of the organisation itself and their organisational requirements. So absolutely have a conversation with that company.
Wonderful, thank you.
You're welcome.
Peter, you've put in a comment here for information about that Sarah Rogers, a paper on falls and adaptive design from the Welsh database. Okay. Any other questions we have for the team? One of the things that I get confused with is all the different terms to use. For example, you had a hierarchy. You talked about co-creation, and in that you had co-design and co-development and co-customization, and but also people talk about co-production. I was just wondering, what's your how do you categorize all these different terms?
Yeah, it's a real challenge actually, because in the Living Lab approach across continental Europe, as mentioned before, then using the terms that I've used are quite common. When we come to the UK, co-production is the term that's used, but it's not necessarily split into the different stages. So how do you engage at different stages? So co-creation and co-production we use synonymously. The stages really is an assessment to see where you're at in relation to, for example, the co-production process. So where are you at? Is it just an idea, or have you actually got something that is tangible and workable as such? And the stages give you the opportunity to look at that. So, for example, if you have an intervention that's already out there and some evidence, and you want to use in a different context, then we would talk about co-customization. But you would still talk about co-production. What we would do would we'd assess where you're at in relation to that process, and what that would mean to the user group as well, used within a different context. But yes, it can be confusing. I mean, I talk about interventions and innovations as well sometimes in a synonymous way, because some interventions that are out there can become innovations when they're used in a different context as well. So we always have to make sure that we describe and say exactly what we're talking about. And certainly within health and social care, they're using all the terms to say that basically the same things that we're talking about.
Thanks, that's really helped me. So that's really helpful. Has anybody else got any questions? I can't see anybody waving at me or anything else in the chat. I just got a question about the application you were using with Alder Hey, really. I was just wondering who was using that, because I'm a GP, so I'm used to the model that we write a referral using our electronic health record to the services, and then they usually print it off onto paper. But who are the users of the app, and how is it going to be used? I wasn't quite clear about that.
So the CIP has one platform is being used at the moment, and any healthcare professional can use it for referral for COMS, but also parents of children under 16 can self-refer their own children, and young people over 16 can refer themselves to CAM services.
Right, okay. So as a GP then, because I'm used to having one electronic way of referring people in, does this mean that I've got another way I have to use?
I think one of the things to think about for us is, I suppose you could say yes, but actually also about self-referral. So what children and young people are saying. So we start with the challenge first. So if we start with the challenge, which is parents and children and young people are saying it's really difficult to access CAM services and we'd like to self-refer, and it's not always going through the GP. So this gives them an option to be able to do that. That doesn't mean it replaces what the GP does. It just means that it addresses the challenge that children, young people and parents have, which is the access to services. And you probably could see that it could be contextualized in mental health services and also other services as well, where self-referral is acceptable if somebody's got a condition that they feel they need, they feel they can need to access services quickly.
Yeah, no, that's good. I like that. I suppose where I'm coming from is the context is that all the different sectors have different ways of recording their information, some using paper, some electronically. And if they're having electronic services, they're all using different systems which don't talk to each other. So that's where I'm coming from. Yeah,
that's one of the real challenges, even in terms of research, is to how to harvest and curate all that data sets. They are scattered across the healthcare system, and how can we bring them together? The CIP as one was also created, try to overcome that challenge. For instance, try to overcome the challenge of referrals arriving to the service from multiple entry points, from GP, from fax, phones, emails, and how to aggregate everything and channel it quicker through the system. And the idea that the platform will try to resolve that. Obviously, as I mentioned, there is the element of how to integrate these multiple systems into one, and that is being developed. So the CIP has been integrated into ALHE healthcare records in terms of speeding up the process of triage and letters of engagement and first appointments. But again, we are still harvesting this data. We can't exactly say for sure there's actually working and how efficient it is.
And as an adjunct to that, we are looking at scale up as well. So how can it be used across the health ecosystem, mainly for children and young people, as we look at integrated care systems, but also it may well be, and this is obviously for ALHE to make a judgment about, it may well be applicable to other contexts as well, if it goes through scale up.
Great, thanks very much. Right, has anybody else got any questions?